Hello and welcome. I'm Patty Keenly. There's a short summary of my professional background at the end of the slides. The title of this presentation is Medication Safety Lessons Beyond the Sharp End, Revisiting the Case Study. Here are the relevant financial disclosures for this presentation. The intent of this presentation is to review the highlights of what you've already learned throughout the course and to demonstrate these concepts through an application to a real case study. With this goal in mind, here are the learning objectives that we're going to be covering in this presentation. These are the key abbreviations and acronyms that will be used during this presentation. Let's go back over the real case that we talked about way back in the beginning of this presentation. A healthy baby boy was born. However, there was a concern that the child might have acquired congenital syphilis. His mother had a history of syphilis, and it was unknown if she had been treated. The mother's medical history was difficult to obtain because both she and the baby's father spoke only Spanish. To be prudent, an order was written for a non-formulary medication, benzathine pen G 150,000 U IM times 1. The pharmacist prepared and dispensed 2 syringes of Permapen, 1.2 million units per 2 ml, in a plastic bag with directions to administer 2.5 mils of the medication to equal 1,500,000 units. The infant's primary nurse, concerned about administering such a large volume of parenteral medication using 5 separate syringes, consulted a nurse practitioner, and the order was changed to IV push to avoid multiple painful IM injections. After administration of approximately 1.8 ml of benzathine penicillin G intravenously, the neonate became unresponsive and resuscitation efforts were unsuccessful. Following the death of the infant, the 3 nurses involved in his care were indicted by the district attorney for criminally negligent homicide. The nurse practitioner and the nursery nurse accepted a guilty plea prior to the trial. The 3rd nurse stood trial, facing a 3 to 5 year jail sentence and permanent loss of licensure. When hearing about this tragic case, as healthcare professionals, we're left with many questions. How did it happen? What went wrong? Who's to blame? Can this happen again? And most importantly, how do we prevent similar errors? So an issue like this really needs a lot of reflection. So do you recognize any similarities in this case study to the medication error events that have occurred in your own organization? And do you think this type of error could happen again? Here's the event report that was initially received. While administering a dose of penicillin IV, the baby became unresponsive. Code blue called. Well, we know that often the information that's first received through a verbal notification or even a written event report like this would be short and factual, but noticeably incomplete, like what's presented here. So clearly, this represents a lack of a number of significant details that would need to be discovered and addressed through further investigation of the systems and then the behavioral choices that were made as well. We can consider a lot of lessons from this Denver case. You can see the newspaper article, Baby's Nurse Faces Homicide Charges. We know that medication errors are complex and almost never caused by a single element in the system or the fault of a single practitioner. So any investigation, to be effective, it needs to be objective, ask the appropriate questions, and sometimes that's a lot of drilling down as to why that happened, fully understand both the active and the latent failures in each situation. So things that we could do as human beings versus the things that are embedded in systems that might point to an error. We want to understand the causes behind each human error and each at-risk behavior, and then consider all of the elements when we're evaluating a case like this. Remember that we want to look at all kinds of the key elements of the medication use process, and ISMP has an assessor, ASSESS-ERR tool that can be used to identify contributing issues that you might want to take a look at. But think of all of these elements that may impact on an error. Patient information, drug information, the communication of that drug information, how the drug is labeled and packaged and the nomenclature that's used, how things are stocked and stored, and is there standardization among things? When we use devices, and if that's involved in a medication error, or actually any medication administration, we need to make sure that that device is used and accessed correctly. What happens with the environment and staffing and workflow issues? How about education, both of the staff and of the patient? And then certainly an evaluation of this involving the quality and the risk management processes involved. When ISMP first investigated this case back in 1996 through an on-site root cause analysis and interviews, there was an identification of close to 50 active and latent failures identified in the case. And the failures can be grouped according to these key system elements. So you'd see them here in the bold type. The investigation revealed all of the key elements were applicable, with the exception only of stock storage and standardization. Let's review those definitions of active versus latent failures. So remember, active failures involve us, between a human. So they're at the point of human contact and some aspect of a larger system. So a lot of times it's a human-machine interface, but not always. Then there are latent failures. So these are generally system failures. They're less apparent and they're based on organization or design or management, but something that contributes to the occurrence of an error or allows them to cause harm to a patient. And it might be understaffing, it might be time pressure. There's all sorts of other things that could be part of a latent failure. Here's a look at the prescribing issues, which occurred both with latent and active failures. So the active failure was the decision to treat the infant for congenital syphilis, but the latent failure there was the absence of prenatal information on the prior treatment of the mother, incomplete clinical information about the current status of the infant for congenital syphilis, and insufficient education for parents about their treatment options. Look at the other active failure here. Benzathine was capitalized, so it almost looked like it was a brand name, and it was written above the word Pen-G. And U for units we know is an issue, and there was some overwriting in that as well. So those latent failures were non-standard communication of a drug order and lack of policies to restrict the use of dangerous abbreviation and dose expressions. We know that the prescriber decided to treat the infant for congenital syphilis despite this incomplete information about the mother's past treatment and the current status of both the mother and child. So this was a decision or an active failure by the prescriber. But when we look closer at this event, we understand that there are latent system issues, such as the lack of a systematic way to gain access to the mother's records and other incomplete issues that are there. Here's a reminder of what that order looked like from the case. So you see how the word benzathine is written above the line containing the penicillin order? And remember, this is a non-formulary agent, so it's something that people weren't familiar with. It may have been done like that as an afterthought or even as a clarifier. However, because it appears above that dose in the order, it led the nurses to think it was a brand name. So when you're looking at the order, it's easy to understand how an overdose of the drug was prepared, dispensed, and administered. This overwriting of things in here, the U for unit, look at how that is there. Now, we may say, gee, that's not going to happen anymore because so much of our information is computerized now and electronic. But think of those as other opportunities for those same kind of failures to occur. And we have to understand that, particularly in clinics and in other non-acute areas in health systems, we still see handwritten orders. Looking deeper into the order processing and distribution pieces of this, you also see latent and active failures. So active failure. misreading the drug information resource from a health department and drug resource. That latent failure is insufficient drug information for pediatric doses, which was rarely used in the practice at the hospital, and the pharmacists and others had very limited pediatric training for this. Another active failure was a tenfold overdose that wasn't detected by the pharmacist during order verification. The latent failure there is no maximum dose warning in the pharmacy computer system, and failure to staff pharmacy with neonatal and pediatric trained pharmacists when you're providing these services. One other issue was a single pharmacist validated the order, prepared it, and dispensed it in that tenfold overdose. Well, that's a pathway to harm when all of those things are done by one person. So those inconsistent procedures for independent double checks prior to dispensing parenteral neonatal doses, and also the preparation and dispensing of 2 full syringes with a label saying note dosage strength. Well, that's lack of patient-specific information for doses to a neonatal unit. We know that there was no technology involved here, so certainly that has improved over time. But again, we have plenty of places in our health systems that are still working on some manual systems. And I think one of the saddest pieces here is these were heroic effects by multiple practitioners and clinicians. But the organizational failure occurred because of all of these other factors that can influence a medication error. Well, as we continue looking at these things, we certainly have to look at the administration factors, right? The active and the latent failures that are involved here. So, a misunderstanding of benzathine to be the brand name for penicillin G, and remember, this was a non formulary selection because folks thought that incorrectly that aqueous penicillin G was penicillin G benzathine. So that latent failure there is that insufficient and ambiguous drug information about the forms of penicillin G, and referring to crystalline penicillin or aqueous suspension is very confusing, not only to us as pharmacists, but also other clinicians that we speak with. The nurse practitioner from an active failure assumed the authority to change the route of administration based on the current license and national protocol and current practice, but there's conflicting requirements for prescriptive authority for non-physicians, and it wasn't defined by the hospital. So we have to remember that whatever we can do as a licensee also has to be able to be approved by our own organization. So even though you might be able to do something federally or even statewide, your individual medical staff needs to approve that type of process within your own health system. There was also an active failure in the decision to administer that IV dose to avoid inflicting pain because it would have involved 5 IM injections. So again, that latent failure is that conflicting drug information and a lack of knowledge of depot drug administration. As we dive deeper into this administration issue and the active and latent failures, the warning on the syringe for IM use only wasn't visualized, so it was unclear manufacturer labeling that was latent failure there. And again, penicillin G benzathine administered intravenously because the latent failure being there was no restriction on that route in available drug information. From a latent failure perspective, the manufacturer's labeling was unclear, and the drug information did not specify that IV was a prohibited route of administration. Here's a picture of the medication syringe that was used in this case. Although the syringe is labeled by the manufacturer as IM use only, the warning was not visible unless the syringe was rotated to the opposite side, 180 degrees away from the drug name. So from a human factor perspective, this warning can easily be covered by the practitioner's thumb. When we go back and take a look at James Reason's Swiss cheese design, look at all of those pieces of cheese that are there. Patient information. There was no knowledge of the mother's prior treatment. Communication. We know it's an ambiguous drug order. Drug information. There were no maximum dose warnings. Drug labeling. That IM was only visible and it was a warning, and it was obscured by a thumb. Staff education, because there was limited expertise in neonatal drug dosing. But the real tragedy in this case is that the death was preventable. From knowing more about the case and thinking about the error prevention, the key system element that had the greatest potential for error prevention was the management of the patient information. Had the prescriber and staff had access to essential information about the mother's past treatment or the health siblings, there would have been no indication for the treatment, and likely that order would never have been written in the first place. So let's take some time here. And again, further on, when you can think about this more, look at some of these reflection questions. So, which of the above latent failures have also been identified in your organization as contributing to serious events? Maybe you don't have good processes in place for sharing patient information between inpatient and ambulatory providers. Maybe your organization doesn't have clear guidance on the role of advanced prescribers in the care of patients. And maybe you have practitioners caring for specialty populations without the proper training or competency assessment. So, what strategies has your organization adopted to limit the risks of these system failures? And even with these strategies in place, do you think this type of error could happen again? And even bringing it close to home could happen again in your own organization. Your participation in this entire medication safety process really points to developing and pushing out some effective strategies. We want the outcomes and goals of using effective things. So obviously we want to eliminate error and reduce risk, right? But we want to also make errors visible and mitigate harm by minimizing the consequences of them. We need to prioritize safety gaps, particularly with high alert medications, high risk populations, and error prone processes. And we want to choose high leverage strategies and kind of consider a rank order in that, because actions should be specific and well communicated. So think of implementing changes. We want to prevent or eliminate that chance of error. We want to implement those strategies that'll make things visible so that they can be caught early and be one of those good catches and not something that really proceeds to an error. And we want to select strategies that are going to minimize the consequences. So we want to mitigate harm whenever we can. Let's take a look at the differences in things that we can do, from the most effective and the hardest to implement down to the least effective, but they're easier to implement. And if you look at these here, they tend to go, the lower ones down at the bottom there are generally human reliability issues. The higher ones and the hardest to implement, but certainly more effective, are those that are system reliability issues. So this is an important hierarchical model, and it tells us that not all strategies are created equal. We need to keep this model in mind when we're developing a plan for sustained system improvement. Good plans involve a lot of strategies from this list and should always strive to use strategies from the top of the list, because they really impact system reliability and are less dependent on human vigilance. Strategies toward the bottom, well, they're certainly necessary and important, but alone they're considered weak because they only impact an individual human reliability. We need to understand the safety gaps that occur in our own organization and prioritize those deficits. And remember to concentrating on high alert medications, high risk populations, and error prone processes will get a lot more impact in making the medication safety team and the medication safety occurrences in your organization in a much larger format. Well, it's been about 30 years since the Denver case, but we still have recommendations that remain. We've learned a lot, but there's still a lot and a need to do better. So keep in mind these high leverage strategies. one of which is constraint or forcing functions. Maybe you want to take a look at this as a case, the antibiotic treatment for orders for congenital syphilis. Maybe they require meeting specific criteria, or maybe that forcing function would be consultation with infectious disease services. Certainly, automation and computerization has improved. A lot of times we can really work with one electronic medical record for a patient, and that's a wonderful opportunity, but that's not always going to present that way. We look at things like medication reconciliation. Obviously, that points toward improving medication safety, but that wouldn't have worked in this case because it was a new order. So we have to kind of balance all of those things that we have. We can't just depend on one thing. But use of CPOE to eliminate miscommunication of handwritten orders and use of dangerous abbreviations and dose expressions has come a long way in 30 years, but still exists out there. So we have to make sure that we're vigilant about that. And the whole opportunity for clinical decision support and information systems has come light years in 30 years. But again, we still need to make sure that we're using it correctly and that we have an active use of things like maximum dose alerts and other warnings that are in the system. We certainly have additional strategies to take a look at, and a lot of it centers on improving access to patient information. The lack of essential patient information was one of the real tragedies in this case. We have to remember that information alone is really a low-level strategy. It needs to be combined with other areas that we have and additional layers, those other Swiss cheese slices, to be able to improve this. We need to improve access to patient information. So in this case, it would evaluating pediatric trained pharmacists on the staff and deploying those pharmacists to patient care units, which obviously is a common thing now, but still not universal, and we need to work toward that. We need to make sure that people are aware of translation resources for non-English speaking patients. That was one of the key occurrences in this, is that lack of communication was there. Standardization of things, order sets, protocols, other issues like that, and certainly employing patient information for clinical support systems in any of our medical records, whether they're electronic or in some cases still manual. In addition to those high-level strategies and low-level strategies, we do have some in the middle. So these mid-range strategies, standardization provides a lot of really good information. We know that up-to-date, standardized, and in particular automated drug information resources is available for use by all the staff. So everybody's looking at that same source of information. We might want to think about always requiring neonatal and pediatric medication orders to include weight-based doses, for example, units per kilogram, and a total dose. So that's one more check in that system. We want to standardize the resources necessary for care of the neonates, and this needs to be 24/7 because babies report into hospitals and other health systems and ambulatory clinics in, non-standard hours. So we need to have that information available all the time. And there certainly should be protocols for use with criteria for infant assessment related to congenital syphilis. All of those mid-range strategies would have pointed to more of those Swiss cheese slices being able to stop an error from getting to this child. Redundancies are essential. So implementing independent double checks. So not one pharmacist who did all of those pieces of the orders, but independent double checks before parenteral neonatal drugs are dispensed from the pharmacy. We need to be clear that low-level strategies contribute to helping this medication error process. It just needs to be combined with other things. So educational programs alone, certainly providing specialty education for practitioners and requiring staff competencies for patients who you need to care for are essential. And rules and policies and procedures and things that develop that include roles of advanced practice providers that are there as well. So these are low-level strategies, clearly important, but they're not going to work in alone. They need to be used in concert with mid-level and high-level strategies to improve safety. Let's take a look at some of the human errors or at-risk errors and reckless behaviors that might have occurred in this case. We know the human error, number one, was that the prescriber decided to treat the infant. So what possible at-risk behaviors would need to be looked at there? Prescriber didn't confirm the mother's prior treatment. Now, the mother had 3 healthy children at home, so it wasn't something that this was a one-off kind of situation. The prescriber didn't have the opportunity or chose not to confer with the mother's obstetrician. And perhaps the nurse didn't pursue the mother's reluctance to provide treatment to her baby before discharge. So either of these things are possible. However, what was found in the case is that there was no reckless behavior that was there. There were some at-risk issues that involved in the case. Let's examine the second human error that occurred. The pharmacist misread the drug reference dose as 500,000 units per kilogram and misread the handwritten dose as 1,500,000 units. And remember looking at that handwritten piece, you can refer back to it if you need to. It's easy enough to do. So a dispensed tenfold overdose occurred. So the possible at-risk behaviors that could be evaluated here, well, from a prescriber standpoint, the use of that dangerous abbreviation U, as we know, it can often be a tenfold error, and here's a situation where that occurred. And the pharmacist manually checking own work before dispensing. So there was no independent double check if that was required in this case. So the third human error, the nurse decided to administer pengbenzethane IV. So what possible at-risk behaviors do we want to look at here? Well, from a prescriber perspective, there was a decision to write over a previous order instead of rewriting the entire order. So the initial route IV benzathine was added above the drug name and thought to be a specific brand name of the penicillin G. The nurse practitioner changed the route of administration based on national protocol and common practice, but not on hospital policy. So remember that bifurcation of what we can do nationally or statewide versus what we're allowed to do in our own organization is key here. Neonatologists failed to document the recommendation from an infectious disease practitioner. The nurse, maybe the failure to communicate directly with the prescriber or pharmacist when questioning the volume of the dose. And remember, these are possible at-risk behaviors that might have been considered in this case. Remember, we need to always consider just culture. So organizations know that human errors need to be consoled, and we're going to make errors. We're human, right? But at-risk behavior need to be identified and coached. So what could have happened in this case? And again, we're looking at this after the case occurred. So these were potential issues that could have been done. The importance of confirming the need before treatment of congenital syphilis is the key issue here. Perhaps that order didn't even need to be made. We have to follow up when the patient expresses concern, because that's a red flag to the system. We need to avoid dangerous abbreviations like U for unit. It's a key area about the importance of independent double checks here, where that tenfold error may have been, let's hope, picked up by someone else who would have looked at it. We need to make sure that our health system policies match the prescribing practices of our clinicians that are there, that there's a proper procedure and an allowance from a cultural perspective to question orders and to revise orders that are there. Use of warnings and auxiliary warning labels needs to be looked at. Something like a check dose strength isn't particularly helpful in many cases to nursing or other clinicians. We may need to provide them with much more information there. and also documentation of external treatment recommendations. So, what else came before? What can we share as colleagues that will help prevent an error in an individual patient? Let's look at some changes that could occur and monitor for successes that can take a look at. Some are structure and some are process issues. So, structural issues could be: has there been a plan established in the organization to care for neonates with possible congenital syphilis according to CDC and AAP guidance? And does it include mandated use of criteria? So, high index of suspicion and involvement of an infectious disease specialist. And is there even an infectious disease specialist available 24/7 for consultation? Another structure issue might be: is there training in place for neonatal care for all practitioner types? So you might want to take a look from a process and structure issue of the percentage of pharmacists and nurses and technicians and whomever caring for pediatric and neonatal patients. Do they have the adequate training that's necessary? And even a higher structure level issue: are there medical staff bylaws based on the practitioner type that govern prescriptive authority? Let's take a look at some of the process measures and questions that could occur. Does the organization require all orders to be placed in CPOE, or might there still be some bypassing of that to allow for handwritten orders or telephone orders or verbal orders when that's not necessary? How about clinical decisions support systems? Are they activated for CPOE and for pharmacists? And have maximum dose alerts been applied for all pediatric medications? You might want to take a look at percentage of orders that aren't in CPOE or the frequency with suspected issues that lack an infectious disease consultation or other similar issues. One other outcome question and measure might be: is the organization screening and treating infants with suspected congenital syphilis according to current CDC and AAP guidelines? So you might take a look at the number of neonates that are unnecessarily treated for congenital syphilis. There are other metrics similar to this that you could use in the organization processes that you have in your own site, but look at this as a similarity piece and be able to extend that and use the information that you've gleaned in this, all of these lessons that are here, for your own activities. As we're reflecting back on this case, which occurred almost 30 years ago, as well as what could occur in your own organization, think of how this all fits in. Should the outcome to the patient influence the organization's response? And has healthcare progressed in its approach to medication errors? Would this response to this error be the same way today as it was almost 30 years ago? When an error involves patient harm, certainly emotions run high, and it's difficult to separate this from the analysis of the error. But take a look at that. If the outcome of the patient's influence to an organization's response, that's a severity bias. So the answer is no. When we treat individuals or systems differently because the outcome of the patient was more severe, that's really something to take a look at. I certainly hope that we have improved in the way we respond to things as we did 30 years ago. But there's medication safety leaders who need to change this paradigm and to make sure that we're moving forward, being more transparent in what's done, and putting those slices of Swiss cheese in place so that system errors don't occur. When we look back at the almost 30 years since this Denver case, there's still recommendations that remain. Fortunately, serious and fatal medication errors are low frequency, but they are high harm events. We have to continue to share those lessons learned. We learn more about errors from external sources, and we can evaluate the applicability to our own organization. So take a thoughtful, stepwise, modified approach if necessary and reevaluate it. We always need to be advocates to patients to involve them and their families in care decisions. We need to be able and have to openly disclose events to patients and families in a timely fashion. When we hide things, that becomes issues of people think we're doing things nefariously, and that's not the point here. We also need to provide care for the caregivers that are involved in medication error events. We know that second victim issue is well there. In summing up what we've learned, we know that medication errors are rarely caused by the failure of a single element of a system or the fault of a single healthcare professional. There's multiple things that generally impact on an error, and a thorough event investigation is an absolute requirement for learning what happened and preventing similar issues in the future. Catastrophic events, like we've talked about in this Denver case, are the result of combined efforts of latent failures in the system and active failures by humans, by individuals, and what we do. We need to look for similarities in system-based causes of errors. So they're the key elements. Those are the things that are actionable, that we can really take an action on and improve. And we always need to be in a process where we can redesign systems based on vulnerabilities that we identify. So we want to employ layers of error reduction strategies, including those that are high leverage. They may be hardest to do, but they're also going to get us further along the path in improving medication safety. Furthermore, we need to understand the underlying causes of the error because that's what is going to reduce that vulnerability to human error. We need to remember just culture separates things. We need to coach at-risk behavior that contribute to medication error events. We also need to help those healthcare professionals recognize risks associated with behavioral choices and the reduced tolerance of risk that is important. We need to take opportunities to share those lessons learned with others internally in our own organization as well as externally. We learn a lot from each other because medication safety is everyone's work. So together we need to consider and continue our safety journey. These are the references that were used to develop this presentation. I'd like to acknowledge and give credit to Sue Paparella, a wonderful nurse, for creating the original content for this presentation. Thanks very much for your time and participation,